Hello and welcome to the next session of hormone physiology, part 5 and part 6. Hope my audio and video are clear. If not, please let me know immediately in the chat box so that I can rectify. In this chapter, we shall be discussing about the adrenal medulla. If you remember my last class of adrenal cortex, I discussed what are the hormones secreted by the adrenal medulla. I also discussed how these hormones are secreted, synthesized, controlled via the pituitary gland or various other controls we discussed in detail. We also discussed the diseases of these hormones, synthesis of these hormones of the adrenal cortex, which was very important point. Now the central portion of the adrenal gland is adrenal medulla. Please remember, medulla is a very little portion that comprises of around 20% of the adrenal gland. So if this is the adrenal gland, this is the adrenal gland, whole adrenal gland, we have got only 20% of the central portion called as adrenal medulla. It secretes catecholamines, the epinephrine and the norepinephrine. It secretes catecholamines, the epinephrine and the norepinephrine. Alright. We'll try to understand what are the major metabolic actions of epinephrine, major metabolic actions of norepinephrine. We'll try to understand. In this chapter, it is utmost important to understand the metabolic actions because we feel that these two, epinephrine and norepinephrine, are not that essential, especially for exam point of view. But that is not the case. Questions are being asked from these areas. So small meticulous points which are exam point of view very important, we'll discuss. We'll also discuss the concept behind what different hormones of the adrenal medulla. So please remember, the secretion of adrenal medulla comprises of epinephrine and norepinephrine. Epinephrine or in few books it will be mentioned as adrenaline, both are same, and norepinephrine. Please remember, there is one important MCQ that comes. Question is, which of these two is the most common metabolite or hormone released by the medulla or synthesized by the medulla? 80% is epinephrine and 20% is norepinephrine. I am talking about the synthesis. If same question I ask, which is the hormone which is maximum in circulation, in plasma, in serum, in circulation. If I ask you in circulation, it is in circulation we have 20% epinephrine and 80% norepinephrine. If they ask you synthesis, it's opposite. The reason is that first important reason is epinephrine is localized in the synapse, in between the two neuronal connection, synaptic channel or neuromuscular junction or synapse, neuronal synapse. Whereas norepinephrine is post-ganglionic, the synthesis of norepinephrine occurs post-ganglionic receptors. So norepinephrine synthesis is independent of adrenal medullary action. For example, what I mean to say by this is, if there is a condition wherein adrenal medulla is lost, if adrenal medulla is lost, then epinephrine levels come down, but norepinephrine levels are normal or equally high because it is synthesized post-ganglionic fibers. It is synthesized by the post-ganglionic fibers. All right. The half-life of these hormones is very less. Around 2 minutes. All right. Whereas whenever these hormones are metabolized, how are these metabolized? There is one important enzyme called as PNMT. It's a transferase enzyme, methyl transferase enzyme. All right, phenyl ethanolamine N-methyl transferase. This enzyme converts norepinephrine to epinephrine. This enzyme converts norepinephrine to epinephrine. Further, the epinephrine is getting converted into metanephrines. These metanephrines and also vanillyl mandelic acid these are the metabolic end products of epinephrine. These are measurable, the metanephrines and vanillyl mandelic acid, both these are measurable in the plasma and urine. In the plasma and urine, they are measurable. Say suppose if there is a clinical condition wherein there is excessive production of epinephrine, norepinephrine by some mechanism, some neoplasia, some tumor which is producing more and more epinephrine and norepinephrine, tumor of the adrenal medulla, that results in a condition called as pheochromocytoma. I'll discuss that in detail shortly from now. So this basically the plasma levels of vanillyl mandelic acid VMA, the plasma levels of metanephrine are increased. The urinary excretion of VMA, urinary metanephrines are increased, so that we can diagnose non-invasively urine levels, checking the urine levels. Non-invasively we can diagnose the abnormalities or abnormal production of the medullary hormones. All right. So as I told you that if adrenal medulla is loss of adrenal medulla, if suppose adrenal medulla is lost, it results in decrease in the level of epinephrine, whereas norepinephrine levels are normal. Why? Because they are synthesized post-ganglionic sympathetic neuron. They are synthesized, they arise from the post-ganglionic. Most of the circulating norepinephrine, it comes from the post-ganglionic sympathetic neurons. And there is conversion of norepinephrine to epinephrine by PNMT, phenylethanolamine N-methyl transferase enzyme. PNMT, I told you this point. What is the action of epinephrine and what is the action of norepinephrine? Epinephrine basically acts on sympathetic receptors and it exerts a mechanism in the heart. It increases the heart rate, it increases the force of contraction. So it has got a positive inotropic and chronotropic reaction. Whereas norepinephrine, it acts on the blood vessels. Norepinephrine acts on the blood vessels to cause vasoconstriction. And helps in maintaining postural blood pressure. So especially the postural changes, suddenly a person stands from a sitting position, it results in release of norepinephrine. Sudden rise of norepinephrine levels will cause vasoconstriction of blood vessels with this postural change, and BP is maintained. You don't get dizziness. But suddenly if there is loss of norepinephrine, what happens is the blood pressure is not maintained. Person develops postural hypotension. So deficiency of norepinephrine will result in postural hypotension, and patient suddenly dies. Patient suddenly gets dizziness or syncopal attack. Sometimes patient will develop orthostatic hypotension and will suffer from various other complications of orthostatic. Postural hypotension, also called as orthostatic hypotension. Hope you are following the class, right? Whereas epinephrine is a stress hormone, epinephrine is it increases in response to exercise, it increases in response to any form of stress like hypoglycemia, like emergencies, like there is sudden blood loss, epinephrine levels rise in the body, like any exposure to cold. Extreme degrees of low temperature, it results in increase in epinephrine levels. All right. So this is an important factor. Let us try to understand what are the metabolic actions of epinephrine in detail, area wise. Like for example, liver. For example, in the liver, the epinephrine levels, it increases the activity of the enzyme phosphorylase, liver phosphorylase and muscle phosphorylase. This enzyme promotes glycogenolysis. If you remember my last class, I told you what are the stress hormones. One of the important stress hormones, counter-regulatory hormone, is epinephrine, because it promotes glycogenolysis. How does it promote glycogenolysis? By increasing the levels of liver phosphorylase, muscle glycogen phosphorylase enzyme. So hence what happens is it promotes glycogenolysis, means the glucose levels rise. It provides glucose levels to the brain, to the body, so that energy is derived and activities performed based on the requirement according to the stress. This is an important metabolic action of epinephrine. Apart from this, in the skeletal muscle, again the epinephrine is promoting glycogenolysis, but here, because there is an absence of glucose 6-phosphatase enzyme in the muscle, glucose cannot be released by skeletal muscle. Instead, it is metabolized to lactate before getting released to the circulation. So from the liver, the glucose that is released, this is distributed to whole body. But in muscle also glycogenolysis occurs. It promotes glycogenolysis. But because of absence of this enzyme, glucose 6-phosphatase, because of absence of this enzyme in the muscle, what happens is the glucose is not released freely outside the muscle. It has to be metabolized inside the muscle only. So there is a glucose utilization inside the muscle only. All right. So the glucose gets converted to lactate, pyruvate cycle, lactate. The energy is released, and this lactate is released out of the muscle. Lactic acid is released out of the muscle, and it is washed off, all right, into the circulation, and gets excreted or used up in some other metabolic pathways. So it's an important action of epinephrine to help in reduction or shedding of glycogen, the stored form of glucose, which is especially during the exercise or stress, when epinephrine is very, very high. We all know that in case of skeletal muscle, this action is very, very predominant. But what happens in adipocytes? Let us try to understand. In case of adipose tissue, the epinephrine increases. In the last class, I told you, adipose tissue, all the stress hormones will, what do they cause? They cause lipolysis, breakdown of lipids, so that the free fatty acids are generated. Glycerol from triglyceride is broken down into minor substrates, and these substrates, the glycerol, free fatty acids, are utilized in gluconeogenesis. All right. Epinephrine increases lipolysis in adipose tissue. It increases all these actions are brought about by an important enzyme called as lipase. It increases the activity of lipase. Epinephrine, it increases the activity of lipase. This lipase, you are calling it as a hormone sensitive lipase. Hormone sensitive lipase. This hormone sensitive lipase, it increases the availability of glycerol, free fatty acids, and other metabolites formed by lipolysis, it is given for conversion. It is taken for the conversion of these fats into glucose, and thus again energy substrate is provided. So we call it gluconeogenesis. Gluconeogenesis is promoted by epinephrine. Epinephrine, thus it increases the basal metabolic rate. Overall basal metabolic rate is increased by epinephrine, similar to the thyroxine, thyroid hormone. Similar to the thyroid hormone, the metabolic rate is increased by epinephrine, but epinephrine never acts alone. It acts in combination with thyroxine. It acts in combination with cortisol to increase the basal metabolic rate. So two hormones it acts in combination with to increase the basal metabolic rate. To increase the basal metabolic rate, it's an important, very, very important point. So to summarize, in the liver, what is causing? It is increasing the glycogenolysis, and plasma glucose levels are increased. In case of muscle, it is increasing the glycogenolysis, but in the muscle, because of absence of glucose 6-phosphatase enzyme, the glycogen is getting converted to pyruvate, then to lactate, then the plasma lactate levels are excreted from the muscle. They are moving into the circulation. In case of fats, the triglycerides, the lipids, the cholesterol, the LDL and all are getting converted, undergoing lipolysis, and the minor substrates, the simplified lipid products like glycerol, triglycerides, glycerol, importantly, it is converted to gluconeogenesis in the liver, right? So these are all the important actions of epinephrine in case of physiological hormone metabolism. There is a condition of adrenal tumors. Now please remember that adrenal medulla is derived from the neural ectoderm. So when I'll be teaching you endocrinology, I'll be talking about this ectoderm, endoderm and mesoderm, the three germinal layers which give rise to all the different parts of our body. These are important because we can understand, it helps us in understanding the localization of a disease and combination of various genetic disorders if there is some problem with the neural ectoderm. So especially in case of adenomas, whereas cortex, adrenal cortex is derived from the mesoderm, coelomic epithelium. Remember that cortex is divided into zona glomerulosa, zona fasciculata and zona reticularis. So zona glomerulosa, fasciculata and reticularis. Please remember, fasciculata comprises of around 50 to 60% of cortex. Cortex comprises of 80% of the medulla, 80% of the adrenal gland. So imagine if you talk about whole adrenal gland, which cell is maximum in number? It is the fasciculata, cells of the fasciculata. The outermost covering of the cortex is called as zona glomerulosa. Zona glomerulosa cells are also called as stem cells because they have a property of regeneration. If there is any loss of cortex, there is a property of regeneration. The cortex slowly grows back to the original levels of cells thanks to the zona glomerulosa, which acts as a stem cell. It has got a stem cell property. Why am I discussing this? Is sometimes adrenal tumors occur which they start secreting epinephrine and norepinephrine in a very, very high manner. So such type of adrenal tumor, you are calling it as pheochromocytoma. We'll discuss that now. Pheochromocytoma is an adrenal tumor which secretes epinephrine and norepinephrine in excessive ratio. These are usually unilateral and benign tumors. They are unilateral, they are usually benign. They are usually benign tumors. They are the characteristic finding in case of MEN2 syndromes. MEN2 is divided into MEN2A and MEN2B. Multiple endocrine neoplasia. MEN stands for multiple endocrine neoplasia. Pheochromocytoma is very, very common in these conditions. MEN2A is also called as Sippel syndrome. Sippel syndrome. All right. So sometimes extra-adrenal pheochromocytomas are also found. The extra-adrenal pheochromocytomas, you are calling it as a paraganglionoma. Paraganglioma is an extra-adrenal pheochromocytoma. Extra-adrenal pheochromocytoma is paraganglionoma. Alright. It is comprising of tumors or neoplastic growth of sympathetic ganglia. They are usually located in the abdomen and they secrete more of norepinephrine. Alright. More of norepinephrine than, so usually they are abdominal. The tumors of the sympathetic glands, sympathetic ganglia. Then norepinephrine levels are very, very high in case of paraganglionoma. The most important feature of pheochromocytoma is hypertension. Please remember this point. The young person presenting with hypertension, severe hypertension, you are using 2 or 3 or 4 antihypertensives, but even then hypertension is not coming down. Then you should suspect pheochromocytoma. The symptoms of pheochromocytoma comprise of headache, sweating, and palpitations. This is called as triad of symptoms of pheochromocytoma. Triad of symptoms. There is, because of increased metabolic rate, patient may also have hyperglycemia. Hyperglycemia. Close the door. Right. Because of increased metabolic rate, because of increased epinephrine, patient may have hyperglycemia. So hypertension, hyperglycemia, headache, profuse sweating, and palpitations. The important finding is pheochromocytoma. Please remember, pheochromocytoma is actually adrenal gland is a supervascular structure. Normal adrenal gland also, it has got rich vascularity. It's very small, but it has got rich vascularity because 24 hours our adrenal gland, cortex and medulla is producing a lot of hormones. These hormones are very, very essential, like aldosterone, cortisol, the androgens, the sex hormones and all are very, very important for us, including epinephrine, norepinephrine. Hence, normally adrenal gland has rich vascularity. Imagine if this adrenal gland tumor comes, obviously tumor will also have lot of rich vascularity, and it is an encapsulated tumor. It results in episodic release of hormone. Timely and episodic release of hormone. This episodic release of hormone is particularly occurring when it is mainly norepinephrine. Norepinephrine is released in a particular pulsatile manner. So norepinephrine release occurs in an episodic manner. There is episodic release of norepinephrine. Now this episodic release of norepinephrine will result in sudden rise in blood pressure. We call it hypertensive crisis. Hypertensive crisis. Now, how to diagnose, how to investigate this case? The most important test here is urinary levels of metanephrine. 24 hours urinary metanephrine levels are the treatment of are the investigation of choice or test of choice. Or 24 hours urinary catecholamines are the important test of choice, which are increased, which help in diagnosis of. There are various other tests to localize. There are various other tests to talk about extra adrenal mass and adrenal mass. We'll discuss that subsequently in pathology chapter or in surgery chapter, definitely. But now what is more important is the most common test that is done is 24 hours urinary metanephrine or catecholamine levels, which are increased. Please remember this point. Pheochromocytoma, is it treatable disease or not? Yes, it is treatable, but if you misdiagnose it, patient may die sometimes. All right, how do you treat this? You treat this by surgical removal. This is the treatment of choice. But whenever you are doing surgical removal, first you will have to ligate the adrenal vein first. Vein ligation should be done first. Why? Because when you are cutting and removing the gland, there is sudden spillage of epinephrine, norepinephrine into the blood circulation that further rises the BP during operation, intraoperative rise of blood pressure, which sometimes causes stroke, hemorrhagic stroke or angina, myocardial infarction and all. So to prevent this, what you have to do, you have to identify the adrenal vein and then ligate it. Once this is ligation done, slowly you will have to cut the tumor and you will have to remove it. All right. Name a type of hypertension wherein salt restriction is not important. Normally, in any case of hypertension, any case of blood pressure, we tend to we advise the patient not to take salt. But this type of blood pressure is such that you advise the patient to take adequate amount of salt, and that is pheochromocytoma. Why? Because if the person does not take adequate amount of salt, it decreases the intravascular volume and person develops shock. Early morning person develops shock, which is not treatable, which is not treatable, and patient may die because of this shock. So salt restriction is not advised in case of pheochromocytoma. Please remember this point. So we have completed the chapter 5 of endocrinology, hormone physiology. Now let us talk about the next chapter, which is an important chapter, pancreas, chapter 6, part 6. We'll talk about various hormones that are secreted by the pancreas. We'll talk about actions of these hormones. We'll talk about diseases of these hormones, important actions of insulin, glucagon. We'll develop some knowledge of diabetes mellitus. We'll also talk about pancreatic, exocrine and endocrine function. If you remember my class in gastrointestinal physiology, I talked about the exocrine function of the pancreas. Now we'll talk about endocrine function of the pancreas. Please remember the cells of the pancreas which are responsible for endocrine function, we call it islets. Islets of Langerhans. Islets of Langerhans. The hormones which are produced by islets of Langerhans, the major hormone that is secreted, the cell type of islet of Langerhans, the local inhibitory paracrine action of each of these islet hormone is also important. And we need to understand the actions of these hormones secreted by the islets of Langerhans cells. We also need to understand if these cells are destroyed by autoimmune reaction or by infection or by trauma, then what will happen, which disease creeps in, which disease starts. Please remember there are 3 important cells of islets of Langerhans. We have got alpha cells, beta cells, and there is no gamma, it is delta cells. Alpha cells, beta cell and delta cell. The alpha cell constitutes 20% of islet cell. It constitutes 20% of the islet cells. The delta cells constitute 5% of the islet cells. So, which is remaining 60 to 75% of pancreas islet cells is made up of beta cells. What are the important hormones that are released, that are secreted by the delta cells? Let us try to understand. The delta cells lie between the alpha and beta cells. The delta cells secrete somatostatin. Somatostatin hormone. The alpha cells secrete glucagon. Alpha cells are usually peripheral in their location, periphery. They are present in the periphery. Alright. The beta cells, which constitute maximum of the islet cells of Langerhans of the pancreas, they synthesize pre-pro-insulin, which gets converted to pro-insulin, which gets converted to insulin and C-peptide. So it secretes pre-pro-insulin, which gets converted to pro-insulin, precursor of insulin. This gets converted to insulin and C-peptide. Insulin and C-peptide in equal ratio. So what happens is, here the blood supply of the pancreas is very important. The blood supply of islet cells is very important. Initially what happens is, the blood supply is basically concentrated on the beta cells. Beta cells receive maximum blood supply. From here the blood picks up insulin and then it goes to alpha cell, the blood small capillaries. Then they reach the periphery alpha cell. There what happens, the insulin inhibits the action of glucagon. There the insulin inhibits the action of glucagon. So initially the inhibition of action of insulin and glucagon are both acting counter-regulatory. They are against each other. One increases the glucose utilization, one decreases the glucose utilization, something like that. All right. So what are the various actions of insulin? We will try to understand. We have got what is known as the insulin receptor. This insulin receptor is facing externally. It has got a hormone binding site. Insulin receptor which faces externally. Say suppose this is the insulin receptor and this is the cell. It has got this area, we are calling it as hormone binding domain or hormone binding site. Hormone binding domain or hormone binding site. The portion of insulin receptor that faces the cytosol, that is this portion, this area, the intracellular portion, this area, it has got a tyrosine kinase activity. Tyrosine kinase is an enzyme. Its activity helps in internalization of insulin and action of insulin on the glucose and peripheral uptake of glucose. So glucose in the peripheral tissues, how is it taken up? In the peripheral tissues, glucose enters by diffusion. Insulin facilitates the uptake of glucose in few tissues, especially where insulin receptor causes because of this insulin receptor there is insertion of glucose transporters in the membrane. So if this is the membrane, this is the membrane. All right, this is a cell membrane. So because of insulin receptor we have got glucose transporters lining up. They help in transfer of glucose by diffusion into the cell. Glucose molecule is entering thanks to the insulin receptor, which is causing upregulation of glucose transporters. GLUT we call it, glucose transporter receptors. There are various types of glucose transporter receptors, especially the tissues which definitely require insulin for the uptake of glucose transporters. For example, adipose tissue. Adipose tissue definitely requires insulin for uptake of glucose. For example, skeletal muscle in the resting state. Especially in the resting state, resting muscle, at rest, the skeletal muscle. In the liver, all right, these are areas where 100% insulin dependent glucose absorption occurs or glucose diffusion occurs, right? Whereas sometimes insulin independent areas, insulin independent tissues are also present. The most important of this is brain. Our brain is insulin independent. Does not require insulin for entry of glucose. Simply it requires glucose. All right. Simply it requires glucose. For example, tubules, renal tubules, kidneys, renal tubules. For example, intestinal mucosa. The red blood cells also do not require insulin for glucose entry. The beta cells of the pancreas. It's like you are a doctor and your family members don't take treatment from you. All right, whenever you are a doctor and your family members don't prefer taking treatment from you. So beta cell of the pancreas has insulin, but it will never prefer insulin as a mediator for glucose transport. It is independent of insulin mediated glucose transport. So that's a very, very important factor and important MCQ that comes from this area to understand the metabolic actions of insulin. Now let us try to understand the metabolic actions of insulin. Please remember, most important point is metabolic action is it's an anabolic hormone. Anabolic hormone. Insulin is an anabolic hormone. What does that mean? Anabolic means it has got a constructive mechanism, constructive pathway. It does not destroy, it does not cause lysis, it causes genesis. When you call about response on carbohydrates, response on protein present in the meals, it's an anabolic hormone. What is the function of anabolic hormone? It converts the raw material in your food to protein synthesis, carbohydrate synthesis. It increases the lean body mass. It increases the protein mass in your body. It increases the carbohydrate mass in your body. All right. Insulin is an anabolic hormone. Other anabolic hormones are thyroid hormone, the growth hormone, the androgens. These are all the anabolic hormones. Anabolic hormones. All right. Apart from insulin. These are all the examples of anabolic hormones. All right. So in case of carbohydrate metabolism, protein metabolism, the insulin increases the uptake of glucose. Once the uptake of glucose is occurring in the muscle and the fat, increasing the metabolism occurs. The metabolism, that is conversion of carbon dioxide to water, is increased. Carbon dioxide and water is increased. Insulin increases the glycogen synthesis in the liver and the muscle. The activity of the enzyme which promotes the glycogen synthesis is increased, like glucokinase enzyme, the glycogen synthase enzyme. So actions of insulin on the carbohydrate metabolism, it increases the glycogen synthesis. By increasing the enzymes, glycogen synthase. By increasing the action of enzyme glucokinase. All right, it increases the glycogen synthesis. These two enzyme activity is very much increased. Because of this, what happens is it promotes the breakdown of it promotes the synthesis of glycogen. It prevents the breakdown. All right, it prevents the breakdown and it promotes the synthesis of glycogen. Glucokinase and glucose-6-phosphate are expressed in the liver but not in the muscle. Please remember this point. They express in the liver but not in the muscle. Just now I told you that glucose-6-phosphate is absent in the muscle. Hence, there is no movement of muscle glucose outside the muscle. Within the muscle only utilization should occur. Right? This is very, very important point. Now, the effects of insulin on the protein metabolism we'll try to understand. I told you anabolic hormone means it is increasing the protein synthesis. How is protein synthesized? It increases the amino acid uptake. Especially by the muscles. So it is because of the insulin, your muscle mass is increasing. All right. It increases the protein synthesis. It helps in increasing the enzymes of protein synthesis. It decreases the protein breakdown. Hence, we are calling it as an anabolic hormone. In case of fat metabolism, an interesting fact about insulin is it increases the glucose uptake by the fat cells. So in the adipose tissue, I told you it is a dependent process by which glucose is utilized in the adipose tissue. By increasing the glucose uptake, insulin makes triose phosphates. What are these triose phosphates? Especially with the triglyceride synthesis, the triose phosphates are nothing but the energy resources of your body. The currency, the energy currency of your body, triose phosphate, ATP, GTP and all is increased. The triglyceride uptake by fat cells, what happens is whenever there is triglyceride uptake by fat cells, it increases, the insulin increases the activity of lipoprotein lipase enzyme, hormone dependent lipoprotein lipase enzyme. Hormone dependent lipoprotein lipase enzyme. Because of this lipoprotein lipase activity is increased, especially in the capillaries, it helps in release of free fatty acids from the triglyceride. It's a very, very important point. Please try to concentrate on this. There is release of free fatty acids from triglycerides, especially in the capillary endothelium. And this action is brought about by the insulin. When you talk about lipogenesis, that is triglyceride synthesis in adipose tissue and liver, this is occurring by stimulation of rate limiting step, that is the carboxylation reaction. The carboxylation reaction of acetyl CoA to methyl malonyl CoA, acetyl CoA to getting converted to malonyl CoA. When I'll be teaching you biochemistry, I'll talk about this again. The acetyl CoA to malonyl CoA, the conversion, it's a rate limiting step. This rate limiting step is increased by insulin, promoted by insulin. Thus, it promotes lipogenesis. Insulin stimulates the conversion of carbohydrate to fat. Please remember, carbohydrates converting to fat thanks to insulin. So tomorrow, if you are using insulin in your patient and the patient complains of gain of weight, it means that the gain of weight has occurred in the form of protein mass. The gain of weight has also occurred in the form of fat mass because insulin converts this carbohydrate into fat. Alright, we all know that one important enzyme, that is a lipoprotein lipase, the hormone sensitive lipase, these two important enzymes, they convert the triglycerides into free fatty acids. The lipoprotein lipase enzyme converts the external triglycerides outside the adipocyte into free fatty acid, whereas internal triglycerides, the triglycerides are present inside the adipose cells, are converted to free fatty acid by the hormone sensitive lipase, and this free fatty acid converted to glycerol again by further various metabolic events. All right, insulin, as it is promoting lipogenesis, glycogenesis, gluconeogenesis and protein synthesis, insulin decreases glycogenolysis, insulin decreases protein lysis, insulin also decreases lipolysis. All right, because it's an anabolic hormone, it is a constructive hormone, it prevents any form of lysis, it decreases any form of lysis. Especially in the adipose tissue, it decreases the lipolysis by decreasing the activity of hormone sensitive lipase. So insulin has got a positive action on the lipoprotein lipase enzyme, whereas it has got an inhibitory action on the hormone sensitive lipase enzyme. This point is very, very important to understand the metabolism of free fatty acid. I'll discuss this again in biochemistry, but there I'll not remind you of all the actions of insulin. You will have to be prepared with this concept, right? The enzymes which are activated by stress hormone, that is stress related, the enzyme which responds during stress are increased, especially the conversion of triglyceride breakdown. The counter-regulatory hormones, that is stress hormones, are counter-regulatory, like cortisol, growth hormone, epinephrine, glucagon. I told you yesterday, the other day I told you 4 important hormones which are counter-regulatory. They are actually against or opposite to the actions of insulin, right? And insulin also reduces the formation of ketone bodies. Insulin decreases it causes negative in the ketone body formation in the liver especially. All right. Exactly opposite happens whenever there is deficiency of insulin. Now, is there any effect of insulin on potassium? It's a very, very important point. Insulin promotes the potassium movement into the cell. If this is the cell and this is the potassium, it promotes the potassium movement inside the cell. Insulin promotes the intracellular movement of the potassium. The overall process we do not know, exact process we do not know, but insulin increases the activity of sodium potassium ATPase, this channel, ion channel. Sodium potassium ATPase. The potassium lowering action of insulin, is used, this action is used in the treatment of hyperkalemia. In case of life-threatening hyperkalemia, especially if it is more than 6 or more than 7 milliequivalents per liter, the value of potassium, life-threatening hyperkalemia can be treated by insulin, by giving insulin in glucose. If patient has normal sugar levels or patient has hyperglycemia, simply give insulin based on the body weight, and that reduces the potassium, intracellular potassium or serum potassium levels to a much better extent. All right. And the beta cell of the pancreas secreting insulin. These are all the important metabolic actions. We'll try to understand the regulation of insulin or control of insulin. What are the stimuli that inhibit insulin secretion? What are the stimuli that promote insulin secretion? We'll try to understand the control of insulin now. What are the inhibitors of insulin secretion? Inhibitors of insulin secretion, most important inhibitor is somatostatin. Somatostatin. The epinephrine and norepinephrine, especially norepinephrine, these are the inhibitors of insulin secretion. What are the promoters of insulin secretion? What are the important promoters of insulin secretion? The glucose is an important promoter of insulin secretion. Amino acids, especially arginine. Then the intestinal hormones like the gastric inhibitory peptide, the glucagon-like peptide. The intestinal peptides are promoting the insulin secretion. Next is the glucagon. Glucagon promotes insulin secretion only to counteract it. All right. Now, these all hormones and these all, the controllers of insulin, they are acting on the beta cell of the pancreas. Drugs also act on the beta cells of the pancreas to increase the insulin secretion. Example is sulfonylureas. Sulfonylureas, common drug which we use to increase the, in diabetes. This also acts on the, beta cells of the pancreas to increase the insulin secretion. So sulfonylureas, they actually block the potassium channels. If the potassium channel is blocked on a pancreatic beta cell, it is a ATP sensitive potassium channel. If it is blocked, that results in release of insulin. All right. This is how sulfonylureas act. I'll talk about this again when I'll be talking in pharmacology, right? The same topic in pharmacology. So to summarize, the most important controller of insulin secretion is, out of all these, it is the plasma glucose. It is the plasma glucose. Please remember this point. The plasma glucose is the most important controller of insulin. A threshold of 100 milligrams % of plasma glucose, insulin secretion is directly proportional to it. Insulin secretion is directly proportional to the level of glucose. Glucose enters the cell, it increases the intracellular ATP levels, and it closes the ATP sensitive potassium channel. Thus the insulin enters the insulin comes out of the beta cell of the pancreas. The closure of ATP sensitive potassium channel, whenever there is closure of ATP sensitive potassium, this results in depolarization, resulting in opening up of calcium channels. The rise in cytosolic calcium, because of increase in the cytosolic calcium, it causes exocytosis of the vesicles that are, carrying insulin, which secrete insulin and also C-peptide. All of the hormones or neurotransmitters named in this slide, which you are seeing on your computer, on your mobile screen, all these promoters and inhibitors of insulin, they attach to the membrane receptors of beta cells of the pancreas. I told you. All right. So the basic mechanism is that if this is the pancreatic beta cell, what happens is ATP sensitive potassium channel is blocked. Because of this, what will happen is the calcium channel opens up. It allows the entry of calcium into the cell. This calcium goes and acts on the vesicles which are storing the insulin. These vesicles pop out insulin and C-peptide because of increased levels of cytosolic calcium. This is the mechanism of insulin secretion. All right, insulin secretion. So this cell which you are seeing on your screen is a beta cell of pancreas. It's a beta cell of pancreas, right? So this is all about the actions of the insulin. Now let us talk about the actions of the glucagon. Let us talk about the actions of the glucagon. Glucagon, please remember, it's a peptide hormone. We all know that it is released by the alpha cells of the pancreatic islets. I'll take a small break. So welcome back. We are discussing about the actions of glucagon now. Please remember, glucagon is secreted by the alpha cells of the pancreas. Alpha cells are located peripherally. Alpha cells are located peripheries of the peripheral islets cells are alpha cells. The glucagon is a peptide hormone and it's a counter regulatory hormone. It opposes the actions of insulin. It has got exactly opposite actions of insulin. The primary target of glucagon action is a liver, that is the hepatocyte. This is the primary target of action of glucagon. The action is mediated by cyclic AMP, second messenger activity. In my first class, I told you how the second messenger activity is affecting the hormone action. The cyclic AMP activates the protein kinase A. Now this protein kinase A, it catalyzes the phosphorylation activity. It alters various enzymes by this phosphorylation. Protein kinase A, it causes catalyzation, or it interferes with the phosphorylation, and hence in the liver hepatocyte various hormones are there are changes in the hormone enzymes, not hormones, enzyme changes occurs. All right, if you remember one important point, that it acts on the liver, it's a very, very important. Another important point is correlate and note that muscle is not a site of glucagon action. Please remember this point. Please remember, it's a very, very important. Muscle, especially the skeletal muscle, there is no action of glucagon on the skeletal muscle. So actions on the liver, let us try to analyze actions on the liver. The first important action is liver, the glucagon increases liver glycogenolysis. If you remember, insulin was decreasing glycogenolysis, it was promoting glycogenesis. Glucagon, it activates the glycogen phosphorylase enzyme, which breaks down glycogen to glucose 1-phosphate. Glucagon inactivates the glycogen synthase enzyme. Glycogen synthase enzyme was activated by insulin. It is inactivated by glucagon. Hence, glucose 1-phosphate is not getting converted to glycogen. So, glycogen to glucose 1-phosphate. Now, this reaction is brought about by glycogen phosphorylase. The opposite reaction from glucose 1-phosphate to glycogen, this is brought about by the enzyme glycogen synthase. So glucagon, it promotes phosphorylase activity. Whereas insulin, it promotes synthase activity, glycogen synthase activity. So the glucagon promotes glycogen phosphorylase activity, insulin promotes glycogen synthase activity, conversion of glucose 1-phosphate to glycogen. Please remember this point. Apart from this, the glucagon increases gluconeogenesis. It promotes gluconeogenesis by inhibition of a very important enzyme called as phosphofructokinase. Phosphofructokinase 2. This phosphofructokinase, if it is inhibited, the 2,6-bisphosphate, glucose bisphosphate, is reduced. This activity is reduced. All right, which in turn decreases the phosphofructose kinase 1 activity. Because of this, what happens? There is inhibition of the glycolysis and there is promotion of gluconeogenesis. It's an important pathway that is promoted by the glucagon. The glucagon, please remember, along with cortisol, along with other stress hormones, it enhances the gluconeogenetic pathway by promotion of one more important enzyme, that is the pyruvate kinase, pyruvate carboxy kinase. Pyruvate carboxy kinase. The activity of pyruvate carboxy and phosphoenol pyruvate, that is PEP, phosphoenol pyruvate carboxy kinase activity, it is increased. This activity is responsible for promotion of gluconeogenesis. Glucagon also stimulates the G6 phosphate, the glucose 6 phosphatase. Hence, glucose is released into the blood. Hence, glucagon can be used in the treatment of hypoglycemia. In the treatment of, because it is increasing the glucose levels in the blood. All right. Next important action of glucagon is the glucagon increases ketogenesis, liver ketogenesis. It promotes the formation of keto bodies. It prevents lipogenesis. Glucagon, it decreases the lipogenesis. Glucagon increases urea synthesis. Urea synthesis. Glucagon increases the insulin secretion. Remember the promoters of insulin secretion, last point I wrote was glucagon. So glucagon increases the insulin secretion. All right, these are all important actions of glucagon. Let us try to understand how this glucagon is controlled. Say suppose this is the alpha cell of pancreas. Let us see what are the inhibitors of glucagon. Let us see what are the promoters of glucagon. So what are the stimuli that inhibit glucagon secretion? First important is hyperglycemia. Hyperglycemia. Next is insulin. Please remember, insulin is an inhibitor of glucagon. Glucagon is a promoter of insulin. Insulin is a bad friend of glucagon. Glucagon is a good friend of insulin. Glucagon stimulates insulin secretion. Insulin inhibits glucagon secretion. Somatostatin inhibits glucagon secretion. So somatostatin inhibits both insulin and glucagon secretion. This point you will have to remember. What are the promoters of glucagon secretion? Hypoglycemia, exactly opposite. Hypoglycemia. Physiologically, hypoglycemia, it promotes counter-regulatory mechanism. Next is amino acid arginine. Remember, arginine also promotes insulin secretion. Arginine also promotes the glucagon secretion. So what will happen? All these promoters, they decrease the intracellular metabolism of glucose and they release the glucagon from the alpha cells of the pancreas. This is how the promotion, this is how the control of glucagon. Please remember that the hypoglycemia is the most important out of all these. Hypoglycemia is the most important promoter of or controller of glucagon secretion. Most important physiological promoter of glucagon secretion is hypoglycemia or low plasma glucose levels. Elevated plasma glucose level is most important inhibitor of glucagon secretion. Most important inhibitor of glucagon secretion is hyperglycemia. Exactly opposite is hypoglycemia. Amino acids, especially the arginine, lysine, such amino acids, they promote the secretion of glucagon. Glucagon is secreted in response to ingestion of protein rich diet, because glucagon resembles secretin. Please remember, secretin is a duodenal hormone. The structure of glucagon and structure of secretin, both are same. If you remember my class of gastrointestinal physiology, I told you at that time, protein rich food, it promotes the secretion of glucagon. All right. So our class has come to an end now. In our next class, we'll discuss how the regulation of glucose occurs and few points about diabetes mellitus to understand the pathophysiology of diabetes mellitus, because this concept helps us in understanding few diseases like diabetes, diabetic ketoacidosis, type 1 diabetes, type 2 diabetes and all. All right. So I hope the class was easy for you to understand. If not, then please let me know. I'll be happy to help with your doubts. Thank you very much.